Obsessive compulsive disorder. Etiology and psychopathology. There is a possible genetic contribution to obsessive compulsive disorder. A significant proportion of sufferers have a previous personality characterized by extreme punctuality, orderliness, and cleanliness. Obsessive compulsive disorder can be accompanied by soft neurological signs. Obsessional symptoms can also occur in a number of organic disorders including Huntington's chorea and Tourette's syndrome. Obsessive compulsive disorder can follow head injury and encephalitis. Studies of cerebral metabolic function show an association between obsessive compulsive symptoms and striatal and orbitofrontal activity. Epidemiology. The prevalence is 1.3% of the general population. Men and women are equally affected. Clinical presentation. Obsessions. Unwanted, distressing and intrusive thoughts, images, or impulses which the patient recognizes as coming from his or her own mind. They are involuntary and the sufferer tries to suppress them, but this resistance only heightens their frequency and intensity. Both the obsessions themselves and the attempts to resist them cause severe anxiety. Compulsions. Stereotyped actions which are carried out to neutralize either the anxiety caused by obsessional urges and images or their imaginary disastrous consequences. The clinical features of obsessions are recurrent, unbidden, unwelcome, distressing, resisted, cannot be got rid of, accompanied by anxiety, lead to canceling out rituals. Compulsive rituals include repetitive washing of hands, cleaning and checking, which provide temporary relief from the anxiety caused by the obsession itself or its feared consequences, e.g. that a blasphemous thought might cause a beloved relative to develop a malignant disease. Compulsive rituals are often performed a specific number of times. Many patients have obsessional doubts, folie de doute, which make them feel uncertain about whether they have actually carried out their rituals, so they then feel compelled to repeat this activity. The content of obsessions is often obscene, sadistic, or blasphemous. The patient might have recurrent ruminations about danger, disaster, disease, or contamination. Obsessions and compulsions can occur in the course of a depressive illness and might remit on recovery from the depression. Differential diagnosis. The main differential diagnoses to be considered are phobias and paranoid delusions. See the specific characteristics in Table 23. NB. Of patients with major depression, 30% have obsessional symptoms, while 30% of patients with obsessive-compulsive disorder also suffer from major depression. Treatment. This consists of either behavior therapy and/or pharmacotherapy. Behavior therapy. This treatment consists of exposure to the environmental triggers that provoke compulsive rituals, e.g. contact with dirt, combined with prevention from carrying out the ritual activities such as compulsive hand washing, prolonged exposure and response prevention. This treatment produces long-lasting improvement in up to 2/3 of patients. Behavior therapy can be supplemented by cognitive therapy, which teaches the patient to challenge the content of the obsessions. Medication. Serotonergic antidepressants such as clomipramine and fluoxetine reduce obsessive-compulsive symptoms, especially where there is concurrent clinical depression. The prognosis is more favorable if obsessive-compulsive disorder is secondary to depression. Complications. Severe depression. Prognosis. The course tends to be chronic.